I'm very happy that you are over there with Mateus, with Dr. Evandro, and he's listening. So a warm hug for you, Dr. Evandro, and your family. Uh, Probably you know when that we are the luckiest neurosurgeons in the world. You, I, and Antonio Musi, because we maybe not luckiest, but the blessed, because we had Evandro in our residency. And after that, at the Beneficência Portuguesa Hospital, and he gave us the unique opportunity, and not more than be with him, but to spend some time with Dr. Rhoton in Gainesville. So let's start it. Okay. So hello, everyone. It's a privilege to be with you in this very special meeting and unique moment. Good morning, friends in Japan, China, and Korea, because it's already Sunday morning over there. I don't know if in Europe they are awake. And good night, friends in Brazil and Americas. So, what I do remember most about Dr. Rhoton is his great energy and unstoppable work to make surgery, the neurosurgery, more accurate and safe through the knowledge of anatomy. And he achieved that creating and disseminating an enormous database of microneurosurgical anatomy among over many years and tremendous effort. We know that. I heard that the most that can be achieved in surgery is the practical use of anatomy. I don't know who said first this, but I learned it from Evandro. He used to say that good is not enough, with that we have also and we have always to pursue perfection with a lot of passion, with discipline, commitment, all based in knowledge and blessed hands by God. This is Evandro. So after I finished my training, I went to Dr. Rhoton's lab in Gainesville, and I had the opportunity to spend some time with Dr. Muratani from Japan and Dr. Eduardo Seuani from Argentina. That was me. I didn't have too much white hair, probably because at that time I didn't have an ex-wife. So we had a nice microscope. We didn't have any digital camera at the time, but we did a great job, a good job, I think. And today I'm going to share with you some my thoughts about the craniovertebral junction and spinal tumors. And please, the youngest, when you see or heard something about neural anatomy, understand that we are talking about microneurosurgical anatomy. So that means the anatomy that you need to know to get your surgery better. We all know that the craniovertebral junction is an area, a funnel-shaped area between the skull and the cervical spine. Where are located very important neural and vascular structures. So let's apply the anatomy to our surgery. And we know that the lower clivus meningiomas or lesions in front of the foramen magnum are a very special challenge for us. Years ago, we had this case, and the young resident asked me, can we do it through the nose to endoscopic surgery? I said, it's okay. And he mentioned, it's a straight and no retraction at brain is needed. Okay, there's no brain over there, but it's okay. It's feasible, but let's think about anatomy. To do so, to the front, we have to drill out the anterior arch of C1. And after that, we have to remove the odontoid process. So looking again to anatomy, in this specimen, we remove the lower clivus and open the dura. And after removing the anterior arch of C1 and the medial portion of the lateral mass and the medial portion of the occipital condyles, we will be able to see the odontoid process. And we see some ligaments over there, the apical ligaments and the transverse ligament. So we have to remove the odontoid, the apical ligament, and the alar ligament that runs from the tip of the dens to the medial portion of the occipital condyle. So we have to remove everything. And after that, we will find the transverse ligament. We can remove it through the nose. We can. We should to reach the intradural space. Can we do it? Yes, it's feasible, but maybe it's not the best. And why? Because we need to understand the craniovertebral junction as a joint. And when we see the 3D anatomy of that, we can understand the relationship of the occipital condyles with the superior surface of C1. We can have some flexion and extension movements of this area. And also we can have a lateral flexion, a little bit, and almost nothing of axial rotation. And if we look a little bit down to the C2, we're gonna see the dens and the superior surface of the C2. And this arrangement with C1 is something like a horizontal shape facet joint. We allowed also extension and flexion movements in this area between C1 and C2. A little bit of lateral flexion. And the most important movement over there is axial rotation, something like 40 degrees. It's half of the movement of the rotation of the arrowheads. And also we can have some movement like this, a translation that doesn't happen because we have the transverse ligament. So if we remove the transverse ligament in our surgery, we're gonna create a huge instability of this region, because this ligament put the proper position of the dens related with C1. So maybe in that case, the better approach is a far lateral approach, a transcondylar. And the resident asked me how we do it. And it's not a problem, it's not a big deal, but it will allow us to see the anterior portion of the foramen magnum and doing suboccipital craniotomy and removing the posterior medial part of the condyle. So in that case, we are able to see in the left side the vascular and the neurostructures. So the VA, pons, medulla, the accessory nerve, and we are able to see the tumor. So this approach, we will be able to see more lateral to the accessory nerve. This will create some space, nice space, to achieve a complete resection of the lesion without retraction of the medulla. So this is the pre-op, the post-op. And how we do it, we remove the occipital bone, something like a extension of the retrosigmoid approach, and we have to remove the posterol medial part of the condyle. And where is our landmark? Is the hypoglossal canal. So as soon as we reach the intracranial part of the hypoglossal canal, we already remove 1/3 of the condyle. And usually we don't need to remove any more to have a nice access. Another important thing that I have to show you is about the VA that runs from caudal to cranial, from medial to lateral, and as soon it crosses the transverse process of C1, it goes down and backwards behind the lateral mass of C1 and over above the posterior arch of C1. So another specimen we can see from caudal to cranial, medial to lateral, crossing the transverse process of C1, go medial, just behind, between the occipital condyle and lateral mass of C1. So it's just in front of you during this approach. So to avoid any lesions of the VA, we need to understand anatomy of that. And the understanding of the suboccipital muscle triangle will help us. I did this video, this is a VHS in 1997 to Dr. EVANDRO. I'm sorry about that. Showing that. So this is the right size. We can show the suboccipital triangle retracting laterally the superior oblique, medially the posterior major hetero, and inferiorly the inferior oblique muscle. And we are able to see the VA. So after that, we can open the transverse process of C1, retract to protect the VA, and we are able to drill the occipital condyle till we find the cortical bone, open it, we will be able to see the venous plexus and the hypoglossal nerve. We open the dura, we will be able to see a very nice space just in front of the medulla, lateral to accessory nerve. So this is another case, a meningioma of the craniovertebral junction, foramen magnum. Someone said that there is no need to remove the occipital condyle in this situation, but I learned that it's not always like that, because I can work laterally, not between the rootless, the spinal rootless of the accessory nerve, because sometimes you have a huge tumor, but very hard and very bleedish. So we have, if you can gain some space, it will be better for you and your patient. And how much we can remove the condyle will create some instability over there. Sure not. We did a study on 1997 with fresh specimens. We did a transcondylar approach, and we could see that it creates an increase of the rotation of craniovertebral junction, but not instability. So you can remove it at all. The posterior 1/3 with not compromise the stability of this region. This is another case. This is a child with a clivus chordoma. In that situation, we try to do anterior approach endonasal, even though we have extension of behind the dens. We have to remember the anatomy. So a good landmark is the sphenoidal sinus. Just down there, we can reach the lower clivus. We are able to see the tumor over there. We have to remember this is a not very large space. We can see the Stechen tube, and just behind that we have the Rosenmiller faucet with the carotid artery. We already can see the dura. And as soon as you open it, you start to see some neurovascular structures. So the VA, In that case, we couldn't remove the final caudal portion. You can see the post-op result. We still have some tumor over there. So we decided to go from the back, like for a lateral approach. You could see the tumor. This is after the first surgery. And after the second, we didn't have any tumor at all. In some cases, we have a huge tumor, so it's not possible to remove it with one approach. In that case, we decided to go from the back because the occipital condyles were already destroyed. So we removed from the back the tumor. We did the occipital cervical fusion, and after that we went from front. And even though we still had a small amount of tumor over there. So we have to apply this anatomy not only to cranial brain, but also to approach spine tumors. So this is a young lady who had paraparesis and low back pain, and we able to see in this MRI a huge lateral schwannoma and not so big in the caudal to cranial. And we decided to do a minimal invasive approach and remove it. The patient did great in the first month. After 2-3 months, he started complaining back pain because we create a huge instability. And why? Even though we did just one level laminectomy, because we didn't respect the anatomy. And we changed the biomechanical, removing the facet joints in the thoracic lumbar spine transition. So lesson learned, we did after that the correction of this deformity, and 6 months later, she had a nice bone fusion. So we have to apply anatomy and get better day by day. This is cervical meningioma, C71. It's anterior to that. We decide to do anterior approach, but we have to remember that space that we need is very small. Even though if I open and show all the medulla, I cannot touch and retract the medulla. So what we do is with a lumbar Casper retractor, we can remove the hemilamina of C7 and T1 in that case, a little bit of the medial portion of the lateral mass without jeopardize the stability of this region. We will be able to see the medulla, the roots, and the tumor, do our microneurosurgery, respecting the same principles. So this is the pre-op, this is the post-op. With no stability compromise, no deformity. This is another case. This is a very calcified meningioma at the upper thoracic spine, anterior to that. We did the same thing, a hemilaminectomy with a Casper retractor. I remove in this case just one facet joint. This is the pedicle, because we have the keep rage. This is very hard tumor. We couldn't cut it. We had to drill it. And clean it. So I will finish now. We're running out of time, saying a lot of work to do. Let's keep working. And let's keep the Evandro's philosophy with knowledge, pursuing perfection with a lot of passion and discipline and commitment. Thank you so much.